Firstly, thank you so much to the organizers for the invitation to be here. It's been a real learning opportunity for me to understand about the scope of cooperation and collaboration across comprehensive cancer centers in Europe. And I hope today to speak a little bit about how we've been engaging in international cooperation and collaboration around at Princess Margaret in Toronto. Many of you may be familiar with this publication. This is from 2001. And in 2001, the Institute of Medicine, which is now the National Academy of Medicine, published this seminal report, Crossing the Quality Chasm, a new health system for the 21st century. And it highlighted how the healthcare system really doesn't deliver on its full potential because of inadequate translation of knowledge into practice, highlighted really as one of the critical factors. And they commented that it now takes an average of 17 years for new knowledge generated by randomized controlled trials to be incorporated into practice. And even then, application is highly uneven. This concept has become known as the Valley of Death in biomedical research, and it's really made to refer to this gap where advancements in basic research fail to achieve clinical translation. And just recently, this publication came out that coined this second Valley of Death, where they talked about how the gap between the medical advances that should be affordable and accessible to all patients and the actual treatments that patients are able or unable to receive is this second valley of death in the translation of our knowledge at a global level. So we have socioeconomic, environmental, political, systematic health system factors that prevent all of the medical advances that many of which we've heard about over the last day from reaching many of the population who can benefit. And I thought I'd show an example of the downstream effect of this second valley of death in breast cancer. This graph shows trends in breast cancer mortality among Black and white women in the United States from 1970 through to 2018. So the red line is mortality from breast cancer, and the bottom is mortality in white women. So top is Black women, bottom is white women, and you can see that if you go back prior to 1980, that disparity in mortality wasn't always the case. And in fact, mortality was higher amongst white women than amongst Black women if you look in the 1970s. And so what changed? Well, we had the introduction of mammogram screening and adjuvant endocrine therapy for breast cancer. And we know that mammogram screening is most effective for cancers that have a longer preclinical phase where it can be detected through an annual or biannual mammogram. And adjuvant hormone therapy is most effective for hormone receptor positive breast cancers. And so the authors of this study talked about, well, why is it that we have this persistent disparity that's really over the last 30 years? And is it just the result of disparities in access to mammographic screening? Inequitable access to medical interventions is often cited as a common reason, and it is surely a real reason that we have disparities in access. Authors of the study discuss that there are some other differences that may be underlying these disparities in breast cancer mortality, one of them being tumor biology differences. We know that triple negative breast cancer is more common in Black women. Adjuvant endocrine therapy is not effective for triple negative breast cancer, and these tumors tend to become more aggressive and don't have as long of a preclinical phase to be detected on mammogram screening. These tumors are often underrepresented in our research enterprise, and in fact, Black women in general are very underrepresented in research. There are real implications of that underrepresentation in terms of trust of the data by both patients and by providers. We see this underrepresentation in research in a global level as well. This is a slide showing disparities in access to breast cancer clinical trials, and you can see that the majority of breast cancer clinical trials are done in higher income countries. And that underrepresentation does contribute in real ways to underuse. This was a survey that we conducted through the European Society of Radiation Oncology, where we surveyed a number of radiation oncologists around the world about their use of hypofractionation for early stage breast cancer. Hypofractionation is using shorter courses of radiotherapy, higher doses. There are thousands of patients who have participated in clinical trials supporting the use of short course radiotherapy for early stage breast cancer, and yet we see significant underutilization of hypofractionation at an international level, particularly in low and middle income countries who were excluded from that research process. And we asked the radiation oncologists who were not recommending hypofractionation why they were not using it. And one of the most frequently cited reasons was that there was a lack of long-term data. There are multiple high-impact publications showing the safety of hypofractionation for these women. Back in 2010, The Lancet came out with this publication where they said that academic medicine needs to take more responsibility for global health. These institutions were seen to be largely independent from economic or political interests, and they have the exclusive role of educating doctors and other healthcare workers and preparing them for the medical challenges and providing an opportunity for the globalization of medical education. And the authors here wrote that neither governments nor market forces can prepare us for the medical challenges within the next 10 years. Research agendas need timely adaptations to medical questions and health issues that will cut millions of lives short from largely preventable causes. And Jeremy Schiffman, who's a professor at Hopkins, took this concept one step further, where he talks about the role of global health networks to promote cohesion, so beyond a single academic medical center. And he defines a network as a web of individuals or organizations linked by a shared concern to address a condition that affects a sizable portion of the world's population. And at Princess Margaret, we listened to some of those calls, and in 2020 formed a global cancer program. Now, this is a structured program within our cancer center that supports and provides coordination to a network of comprehensive cancer centers and research institutes and NGOs internationally who have agreed to collaborate on areas around education, clinical care, innovation, and research. And I'll focus today mostly on the research collaborations. When we launched this program, we did so really with the idea that we didn't just want unilateral or even bilateral partnerships. We really wanted to form a network of centers who were committed to collaborating with each other. Recently, we've, about a year and a half ago, we brought a number of the leaders from these institutions to Princess Margaret to have a discussion about how we want to collaborate together. And out of that meeting formed 5 working groups with 70 different faculty engaged from across our participating cancer centers. And actually, it was someone from DKFZ who created this map that showed some of the collaborations across this network in research, in education and training, in clinical guideline development. And so one of the core issues that we wanted to address is how we can build a collaborative research hub. We wanted to support research that was investigator-initiated, that was global and inclusive by design, that was innovative, pragmatic, and feasible. We've since awarded 18 different seed grants in many different areas around clinical trials, translational research, qualitative research, and we focused on key thematic areas, the first being prevention and early detection, the second being clinical trials, and the third being patient experience. And all of these seed grants touch on issues related to health equity or implementation science. And I thought I'd give a few examples of some of the research that's come out of this program. We spoke earlier already around some of the disparities in mortality from breast cancer, and those disparities are not just seen in the US or in the North American context or in Europe, but they're seen internationally. And we know that there are some differences, as we've talked about, in the biology of disease that some women are diagnosed with. In North America, we have guidelines that recommend germline testing for breast cancer amongst all newly diagnosed patients under the age of 65 with breast cancer, as well as those over 65 who have certain disease characteristics or family history. And so we wondered whether this could be applied in the international context to address some of the disparities that we were seeing. And so out of this was born the ACTION study, which is a study on addressing global inequities in breast cancer genetic testing, counseling, and management amongst breast cancer patients in Nigeria. We had a breast surgical fellow who came from Nigeria to train at Princess Margaret, and one of the issues that she realized was there was a real lack of access to any kind of genetic testing or counseling in Nigeria, and they really didn't know how prevalent many of these mutations were in their population. And so we partnered with the African Research Group in Oncology to understand the feasibility of BRCA testing amongst Nigerian breast cancer patients. And this was really coupled with a strong implementation science component where we looked at developing and assessing educational curricula for healthcare providers as well as patients and their families. This study has now expanded to other international sites. Just this month, the WHO released their global action plan to strengthen clinical trial ecosystems. And in particular, the plan outlines priority action areas to build clinical trial systems internationally that are fit for purpose, inclusive, and locally led. And we've already heard this morning and yesterday about some of the issues in clinical trial representativeness and ways to increase collaboration across different international sites. With that in mind, we launched the first clinical trial through our global cancer program, and this trial is called PRESERVE, and it's a prospective phase 2 study of breast preservation in women with recurrent breast cancer who were previously treated with breast-conserving surgery and radiation. The goal of the study is to allow women with recurrent breast cancer to avoid mastectomy. And we spoke just earlier about how many trials come out of the example of a single patient. And this is another example where we had an international fellow, actually from King Hussein Cancer Center in Jordan, and we had a patient in the clinic who was an older woman who had been treated with a lumpectomy and radiation in the past, and presented now, did not want a mastectomy, and couldn't come for any kind of long radiotherapy course. And so we had a discussion about whether we could develop a trial that would address women like her and the presentation that she had. We know that mastectomy can be associated with depression and anxiety, impaired sexual functioning, reduced quality of life, and delayed presentation to the healthcare system, especially in parts of the world without access to reconstruction. The study is testing the use of ultra-hypofractionated partial breast radiation after repeat breast-conserving surgery for women with local recurrence. This is a relatively easy-to-deliver, low-cost therapy and was designed with patient engagement in defining the endpoints. This is just a snapshot of some of the participating sites. It's open across, I think, 11 sites right now, and there's several others internationally that are in the process of opening. And we've been inclusive of low and middle income countries in this process with sites in Brazil, Jordan, Malaysia, Kenya, and India. The last intervention I'd like to, or the last study I'd like to address is a project looking at patient experience and psychological well-being. At Princess Margaret, we routinely screen all patients coming in the cancer center for distress. We look at physical symptoms, practical concerns, emotional concerns, and we've heard already about P4 medicine and being able to deliver personalized therapy. This uses patient data at the point of care to direct therapy and to allow opportunities for intervention, and we call this the sixth vital sign. This is work at Princess Margaret led by Dr. Madeline Lee, who has partnered with Aga Khan University in Kenya to develop the first comprehensive distress screening in Africa. This is now being implemented. This distress screening tool has been culturally adapted and translated and has been piloted in breast and prostate cancer clinics at Aga Khan, with currently being expanded to all medical and radiation oncology clinics. This was really done again with a strong capacity building implementation science framework. We had clinical psychologists who were trained, and now it's being implemented with their engagement across the cancer center with high patient satisfaction. We realize that international collaboration on research does require a strong skill set, and so we've coupled our collaboration on research projects with opportunities for research training. Our phase 1 clinical trials program has been participating in a number of research training initiatives. This one is being led by the Malaysian Ministry of Health. As I mentioned, we have ongoing collaborative trials with them, and our clinical trial phase 1 unit does provide training to their research coordinators at a national level. My colleague, Dr. Rebecca Wong, has also led a longitudinal research mentorship program for radiation oncology residents through aortic in Africa, really wanting to mentor and nurture the next generation of oncologists to ask the right kinds of clinical questions and understand how to develop research from them. And then finally, one of the programs that we're particularly proud of is our Global Oncology Leadership Development Program. Princess Margaret has a unique setup where we have close to 200 fellows that come to Princess Margaret every year to train across the different disciplines, and about 75% of them are international. And they obviously come to Princess Margaret for clinical training, but many of them are expected to go back to their home institutions and take up important leadership roles. And we realized this was really a gap in their training. And so we launched this program, which is offered free of charge, with support from the leadership of our hospital to develop and train them in transformative leadership skills, inspiring them to think big about how we can address cancer challenges and provide infrastructure for mentorship and alumni. We've done some work to evaluate this program along the way, and we've done a qualitative study to look at the impact of the program. And I thought this quote was particularly poignant. One of the participants said, "I thought leaders were born before gold. I did not think I was leadership material." This individual has gone on to become their department head. At a time when it feels like all of the world is starting to look inward, I felt particularly proud to see that the Canadian Academy of Health Sciences has renewed its commitment to global health across all of these domains in education, research, networking and knowledge mobilization, and capacity building. And as a final note, over the last number of years, we've developed a network within Canada of comprehensive cancer centers who are committed to working in global oncology, and in this to be able to coordinate activities at a national level as well. So with that, I'll close. I think we have a significant gap in knowledge translation that leads to underutilization of new discoveries and perpetuates disparities in cancer outcome. We've already heard a lot over the course of this meeting about how collaboration between comprehensive cancer centers is critical to close the gap in knowledge translation and to deliver on the promise of P4 care to diverse populations. We need heterogeneity in research populations to be able to apply the results to diverse populations. We need large sample sizes to answer important clinical questions. And we know that participation in research encourages application of the data into clinical practice. Our network of global comprehensive cancer centers, we hope, demonstrates proof of concept on the opportunity to apply locally generated knowledge globally and globally generated knowledge locally. So with that, thank you to everyone who contributes, and happy to take any questions.